You can go ahead.
Okay, afternoon, everybody, and welcome to this G-Echo session, which is hosted by the Gastro Foundation in association with Project Echo, University of New Mexico. These sessions are held weekly on a Wednesday. The chat will be open for questions. So I think we're a little bit behind where we should be in terms of starting. So our speaker for this afternoon is Shaun Temmers. Shaun is a recently certified subspecialist in GI, and he presently works in PMB and spends a bit of time with us still at Albert, the hospital in Durban. So, Shaun, you're going to be speaking to us on some pseudo polyps and strictures in ulcerative colitis. So maybe you can start to share your screen, and I'll hand over to you, Shaun.
Hi, just give me a second. Let me just see. Doesn't seem to want to go to the share screen. No.
Okay, we can see something now.
Am I sharing anything?
You sharing your
Am I sharing something now?
yes, you are. We can see a slide.
And now?
Okay, you're trying the full screen. Let's just give it a second. Maybe it will.
You at the end of your slideshow, just go to the beginning.
Oh, page there. Sorry for the delay. Just see what's happening here. Am I still sharing?
Not yet.
Not yet.
It's coming up.
And now?
Yeah. There we go. All
Yeah,
good.
that's perfect. And
Okay.
Cheryl, by the way, I am back for the moment.
Okay. All good. Thanks, Jill.
Just gonna this here. I can see.
Hi,
Okay, sorry
Jill.
for the delay. Yeah, so we're actually just going to be focusing on the management of colonic pseudopolyps and benign strictures in patients with ulcerative colitis in remission, as opposed to covering the entire subject matter. So we'll start off with a case scenario, and we'll look at our first case here. And this is a 38-year-old teacher who was diagnosed with a pancolitis about 4 years prior. Initiated on 5-ASAs, tolerated it quite well. And after induction, subsequent to recent CRP about a few months ago was 3 and a calpro of less than 50, had a hemoglobin of 13 and a ferritin of 80. No extraintestinal manifestations, and currently has 1 bowel movement a day. Now, his colonoscopies and sorry, this thing is just blocking my view. So his recent colonoscopies over the last 6 months, 18 and 3 years, which is illustrated in the still images below, showed these mucosal growths that we can see in image A, and there's quite a few of them, and they persisted despite him being asymptomatic. If you look at the most recent one, there was this quite large lesion that was removed in its entirety at endoscopy. Histology of those resected lesions all came back with features consistent of pseudopolyps or post-inflammatory polyps, but there was no dysplasia. And over the course of the last 4 years, they had about 5 endoscopies, and the histologies have remained fairly similar, and he's remained asymptomatic on 5-ASA therapy. Look at our next case here is a 52-year-old shop owner. He was diagnosed with pancolitis as well 15 years prior, as well initiated on 5-ASA therapy. And he had a last flare just over 8 years ago, short course of steroids, went into remission and has been on oral and topical 5-ASAs since. Last week, calprotectin 3 months ago was less than 50, with CRP of 4, hemoglobin just under 15, ferritin of 18. It's a non-smoker, doesn't report any weight loss, again, single bowel movement, form stool per day, and there's no obstructive symptoms. He's had multiple colonoscopies over the course of his disease process, and it's noted on most of his colonoscopy reports that there's a narrowing at the sigmoid and transverse, and a gastroscope is required. At every endoscopy, these narrowings are transverse, and they sampled at both the anal and oral ends, and the histology returns with no activity and no dysplasia. And this is a repeated finding for this patient on roughly a 2 to 3 year cycle. When we look at pseudopolyps in ulcerative colitis in patients who are in remission, pseudopolyps or post-inflammatory polyps, they are islands of regenerative mucosa amidst ulcerated tissue. They occur after severe or repeated inflammation, and it's a common finding in long-standing ulcerative colitis. It's known that they are usually benign, but can be complicated, they can complicate surveillance of these patients in the long term. The important part here is that they obscure mucosa and they can hide dysplasia in patients with chronic colitis. We look at the prevalence of these lesions in patients with IBD. Across most published cohorts, it's a vast range. It ranges from anywhere between 4 and 74%, but it is noted that it is less common in Crohn's disease than in ulcerative colitis. They're more frequently detected within the colon itself, but they can occur elsewhere within the GI tract. So-called giant post-inflammatory polyps are typically defined as those lesions that are bigger than 1.5 centimeters. The pathophysiology and the significance of these lesions are quite intriguing. Since there's no transmural inflammation as we see in Crohn's, they are a result of mucosal regeneration following intense or severe ulceration. They represent past and not current inflammation, and they also give as a mark of previous severity of disease or cumulative inflammation over time. Importantly, they can present with rare complications such as bleeding and obstruction, and they might make surveillance endoscopy quite difficult, especially when they become matted or when they grow across the mucosal lines to sort of form these joint crossed growths. So we had a look at what the literature says in the current guidelines with regards to the management of these lesions in patients that are ulcerative colitis that are in remission. So I've sort of summarized it in this table on this slide. We go through it just to get an idea of what the international consensus is. The American Gastro Association, their recommendation is that we should do targeted biopsies for all these lesions, and we should only biopsy lesions that endoscopically are of concern, and surgery should be a last resort for this patient. The interpretation of that statement is that post-inflammatory polyps should not be cleared, but only sample atypical lesions, and surgery only when surveillance is not feasible. If you look at the ECHO e-guide, they listed post-inflammatory polyps as a risk factor or high risk factor for colorectal cancer, and they suggested a 3-year surveillance for all patients that are in remission. And they made a sub-statement to say that you should also individualize this patient. The ACG in 2019 emphasized that remission should be maintained, and they advocated for the use of high-definition endoscopy as well as chromoendoscopy to identify early lesions. The BSG later advocated for the involvement of an MDT approach for patients where surveillance becomes quite complicated. And if you look at consensus data or reviews, again, just reiterates that post-inflammatory polyps are marks of prior inflammation, does not actually indicate current or recent disease. And medical therapy on its own should not be solely changed due to the presence of post-inflammatory polyps. Then when the colorectal neoplasia or colorectal surveillance reviews, again, emphasize that visible neoplasia should be resected, And where there is an uncertainty with dysplasia, these patients should be discussed in an MDT involving the surgeons, pathologists, and the gastroenterologist to determine the best form of follow-up and management plan for patients. Considering the scattered views from different societies across the world, how can we look at the management principles as a whole? So it's clear that we need to maintain deep remission and continue maintenance therapy and to aim for mucosal healing. It's clear that high quality surveillance colonoscopy is advocated for all patients and high definition scopes should be used. Chromoendoscopy as well as targeted biopsies of suspicious lesions should be applied. Risk-adapted surveillance intervals are important in pseudopolyps because they overall infer moderate risk, and therefore a surveillance period of not more than, or gap of not more than 3 years should be advocated for patients. Important to note that no prophylactic removal of these lesions is warranted, and only this plastic lesion should be removed, or if a patient is symptomatic from their PIPs. Now, iEcho and the AGA advocates for a risk-stratified surveillance approach to individualize these patients. And you can sort of break it down into individual surveillance periods. We will say 1 year surveillance for high-risk patients, and what defines the high-risk patients is those patients that have concomitant PSC with this prior high-grade dysplasia, a history of colorectal cancer, strictures where dysplasia has not been fully excluded or not fully resected, those that have extensive disease, especially those with severe inflammation, the sort of moderate or intermediate group, or 3-year group, is patients that have a multitude of post-inflammatory polyps, where they've got extensive colitis, and they are in remission, where there's some family history scenarios of cancers that would reduce the risk for the time frame for screening, and there's some other moderate risk factors, patient-specific in itself, unrelated to the colitis. And your sort of low-risk patients, where you can opt for sort of 5-year surveillance in these patients, is those that have limited left-sided disease. They've been in long remission with repeated normal exams, and there's no additional risk factors. Important to note that this category is only warranted for patients where you've had multiple normal exams and you've made a shared decision-making with the patient, indicating the risk of missing unseen dysplasia. The surveillance techniques that should be opted for these patients is, again, high definition white light endoscopy with the use of either dyes or sprays or chromoendoscopy to identify flat lesions. Targeted biopsies, for those that aren't aware, is where you find anything that's got an irregular surface, where there's nodularity, or you've got vascular distortion. Those are the areas that you want to biopsy in these patients that have PIPs. More importantly, you need to document any lesion that is found or resected and its location for comparison, especially for follow-up. Because more times than none, the repeat endoscopy will be done by endoscopists, will not be done by the same endoscopist as the initial endoscopy. When should we then consider surgery for this patient, and is that even an option? So surgery is indicated for patients with PIPs where surveillance is inadequate. And here we're talking about dense polyposis, where you're unable to navigate a colonoscope through the colon, or you get obstructed due to the dense overlay of the pseudopolyposis, where you have invisible dysplasia. There's still ongoing concerns that there might be dysplasia in a patient in the area of the colon that you could not reach. In patients that are symptomatic, so there's recurrent bleeding, or those that present with obstructive symptoms, surgery should be considered. But surgery should only be advocated in a multidisciplinary approach consisting of the individuals as mentioned before. The nature of the disease is that it's in remission, and it's important to understand that counseling of the patient becomes important. You want to maintain standard UC maintenance therapy for which the patient, for which you receive remission of the disease in. You need to reinforce adherence to the surveillance interval, whichever one you choose, whether it's 1 or 3 years. And then here it becomes important to educate the patient, because they need to be aware that yes, there are pseudopolyps, but it represents scar tissue and it's not cancer. However, the risk of cancer is still present. And important that all endoscopists are involved in the management of these patients adhere to high quality colonoscopy techniques and should upskill if they are not. So how would we go about proposing a management flow chart for these patients, looking at what the current recommended guidelines show us? So we want to confirm the diagnosis endoscopically. It's typical endoscopic appearance, as well as sampling lesions to get a histological diagnosis of pseudopolyp. You want to maintain remission. Standard UC therapy is recommended, and there's no need to up-escalate therapy in those patients. You want to implement a surveillance strategy for these patients, and you want to use high-quality surveillance endoscopy, implementing virtual chroma endoscopy with high-definition scopes. Targeted biopsies of suspicious lesions in all patients with PIPs. And a 3-year interval is typical for patients, but you can individualize it and reduce it depending on the risk strategy. It's highly unlikely for a 5-year interval to be chosen for most of these patients. And then surgery only if visualization becomes inadequate for the patients. What about colonic strictures? So here again, if you look at the prevalence of colonic strictures in ulcerative colitis across most of the published cohorts, again, it's less common, between 1 and 11% overall, and it's much rarer to find colonic strictures in patients with ulcerative colitis than it is for those with Crohn's disease. The risk rises with long-standing disease and the extent of the colitis, which is more common in pancolitis. Typically affects the distal colon, the sigmoid and descending colon, but it might occur anywhere within the colon itself. It's two forms. You get an inflammatory or edematous narrowing, and this can regress. However, fixed fibrotic strictures may persist. The importance here of colonic strictures in patients in remission, they indicate a new or worsening stricture. You need to exclude dysplasia or colorectal cancer in that patient. The pathophysiology of stricture formation within ulcerative colitis is slightly different because there's no transmural inflammation. But here, because of injury and ulceration and this repair cycle that occurs, you get sort of fibrostenosis that does happen. It's much less common than what you see in Crohn's with the transmural inflammation. So this deep ulceration triggers granulation tissue activation, and you get all this pro-inflammatory activation that occurs with extracellular matrix accumulation of collagen 1 and 3 within the submucosal, and this leads to submucosal fibrosis and architectural distortion. Further, muscularis mucosae hypertrophy occurs with hyperplasia smooth muscle with some luminal narrowing. There's associated microvascular or ischemic changes, and this can be related to recurrent flares, and this will then promote remodeling. As mentioned before, there's a spectrum of disease. Initially, there's a reversible inflammatory narrowing, and the patient can either return to a completely normal colon, or you get this sort of fibrotic pathway and a fibrotic fixed stricture is then formed within ulcerative colitis. As for the polyps, I had to look at what the recommendations and guidelines are for the management of these patients, and I tried to summarize more in another table as illustrated in this slide. If you look at what the American Gastro Association, ACG's updated guidelines from this year suggest 4 strictures in UC that are in remission. Again, they advocate for high-definition colonoscopy with chroma and virtual endoscopy. Here, the targeted biopsy is important from where you're biopsying. You want to biopsy the base on the rim of the stricture, and you can do so safely. And you want to make sure that that stricture is transversible or not, so you can measure the length of the stricture, as well as biopsying the proximal end. Therapy is then indicated dependent on the length of the stricture, and short endoscopic therapy is warranted. But steroids, just for the presence of a fibrotic stricture in an asymptomatic patient, should be avoided, as well as deployment of stents. Surgery here is indicated if you are unable to transverse a stricture, the evaluation is incomplete, or there's other indications for surgery. The threshold for surveillance here, because it's a high-risk feature, should be shortened. On average, should be done somewhere between 1 and 3 years, with a propensity to repeat surveillance at 1-year intervals initially. The ECHO colorectal guidelines, colorectal cancer surveillance guidelines for benign strictures follows a similar pathway where it states that all strictures in UC are cancerous and or cancer should be excluded, and all effort should be made to exclude malignancy in those patients before labeling them as benign. Again, once it's been confirmed that it's benign, endoscopic therapy in selected cases where it's appropriate, and again, surgery for where surveillance becomes inadequate or you're unable to transverse that stricture. Again, intervals here favors a shorter period between 1 and 3 years, but should not exceed 3 years. And invariably, these patients will have other risk factors to reduce the interval surveillance, especially if they are in remission. If you look at the PSG guidelines, here they emphasize time to remission. And the rationale here is that early therapy, aggressive immunosuppressive therapy, will reduce the time for stricture formation. However, the evidence for that that is cited is quite weak, and stricture formation can still occur despite early intervention. Again, endoscopic and surgical management follows similar suggestions from both ECHO and AGA. And again, they looking at risk stratified surveillance follow-up periods from both 1 to 3 year period. The American Society for Colorectal Surgeons, their recommendations and guidelines are fairly simple. They say if a colon cannot be safely evaluated across a stricture, you should prioritize oncological safety for the patient. And endoscopic option should only be tried once a benign stricture has been confirmed. Surgery is advocated for non-transversible or long strictures. And interestingly, the surveillance period that they suggest is to discuss it with gastroenterology and whatever the gastro societies suggest for surveillance in these patients in remission. As a consensus, though, if you look at some consensus papers and reviews, the point that is labeled back is strictures in UC, even in remission, you should consider malignancy. And once you've ruled that out, then and only then you should treat it as benign. They also reiterate the introduction of multidisciplinary approaches for these patients and to be selective in which patients should require surgical or non-surgical intervention. There's advocacy for surveillances in patients who are in remission, especially with the use of high definition endoscopies with both chroma and virtual endoscopy to improve detection in these patients. So how can we summarize that information into our options for therapy and decisions on when to operate? So we can break it down into patients that would require endoscopic therapy. And here, if we find a stricture that is short, about 4 to 5 centimeters, it's straight, it's accessible, those patients would benefit from endoscopic balloon dilatation. You would consider stricturotomies in patients where balloon dilatation is either refractory, but it's important that this should be done in an expert center or in a high volume center. And stents rarely used in these cases due to the risk of migration and complications. Surgical options, as stated previously, if it's a non-transversible long stricture, if there's multiple strictures, if you have persistent doubts that this is cancer, it's unresectable, or there's failed endoscopic therapy. What's the role of medical therapy in these patients that are in remission? Is to maintain deep remission. You don't need to escalate therapy for fibrosis alone, and you want to treat in the inflammatory component first. And once that is settled, you would then opt for endoscopic surgical therapy if the patient is symptomatic. It's important to then coordinate a multidisciplinary approach to the management of these patients. So with benign strictures, where do we start? Well, we first detect the stricture. We presume it's malignant until we've excluded malignancy. Once we're happy that it's benign, our next step is to then do high definition high definition colonoscopy with chromovirtual endoscopy and do targeted biopsies around the base and the rim of the stricture, transverse the stricture, and biopsy the proximal end. If it's benign, it's transversible, and the patient is asymptomatic, those patients you can observe, and you can shorten the surveillance between 1 to 3 years intervals. If it's benign and they are symptomatic, if it's short and straight, it's easily accessible, endoscopic therapy with balloon dilatation is your first point of therapy, and you might repeat that as needed up to 3 times a year, depending on the center that you are in. If it's refractory or complex, those patients you would opt for a stricturotomy or in an expert center or surgical resection for those patients. And then it's important to remember during the course of this assessment is you want to retain remission with no escalation required for fixed fibrotic strictures alone in that setting. So in our practice, what did we do and how do we manage these patients? Well, we seemingly follow the thought process of confirming whether it's benign, and we use the modalities available to us. We use HT scopes with both chromo and virtual endoscopy. We've done targeted biopsies from these lesions and sample them from the base where they're safe. If the strictures have become not transversible, imaging was ascertained, and then with discussion in the patient for surgery if we're concerned that these patients have malignancies. What about the symptoms? If we find short strictures and the patients are asymptomatic, we leave it alone and survey them. However, if they're symptomatic, we offer them balloon dilatation if they're agreeable to it and repeated sessions. However, we avoid the use of steroids as well as stent placement. Refractory symptoms, we would often refer across to our surgeons who would decide on either surgery or stricturotomy depending on expertise. But importantly, we survey wisely, and we perform surveillance during the croissant phase of the disease. Most of these patients have their follow-up endoscopies somewhere between 1 and 2 years, up to 3 years for some of them. And at every sitting, that stricture is assessed, looking for high-risk features, and we map the anatomy. Whenever there's concern, we involve a multidisciplinary team to discuss, especially if we suspect that there is dysplasia present. So what are our key takeaways with PIP, post-inflammatory polyps and strictures? Well, post-inflammatory polyps are markers of prior infection. They do not indicate malignancy. Whereas with strictures, we want to exclude malignancy first before labeling it as benign. The focus in both is deep remission and high-quality surveillance with adequate surveillance periods depending on the risk stratification of the patient. For PIPs, we do selective biopsies of atypical lesions, and there's no need to clear the colon from the post-inflammatory polyps. 3-year surveillance colonoscopy seems to be typical for most patients with PIPs due to the low risk of malignancy, though low risk of dysplasia, though the risk is still there. And surgery then only if surveillance is inadequate. Whereas in strictures, surgery should be considered once you're unable to transverse the stricture proximally and you cannot assess the RON of that stricture. MDT is early in the course of the management in patients with strictures, but should be considered early for patients with PIPs as well. So if you want to simplify a management approach to patients with pseudopolyps, there's a little diagram I had created, and we look at keeping continued maintenance therapy for the ulcerative colitis. Each patient, unfortunately, you need to individualize a tailored surveillance colonoscopy approach depending on their risk stratification. We remove selected lesions that show dysplasia, And you must discuss patients for surgery, especially where surveillance becomes an issue. Slightly different in stricture management. This infograph just shows you that malignancy again needs to be excluded because we assume everything is malignant until it's excluded. Once you've done, and your tools for doing that is using high definition colonoscopy with chroma and targeted biopsies. If it's not transversible, get imaging. If in doubt, discuss the patient with your surgical colleagues to plan for best timing of surgery. If you confirm that it's benign, two things you need to do is the patient find out if the patient is asymptomatic or symptomatic. If they're asymptomatic and it's transversible, you can observe those patients. If they are symptomatic and it's short and accessible, balloon dilatation seems to be safe and it can be repeated. Refractory lesions, you can then opt for either stricture or neurosurgery, depending on surgical expertise in the center that you're working in. But important in both cases is to maintain remission, and there's no need to escalate therapy for fibrosis alone. And when unsure, discuss patient care within a multidisciplinary team. These are just some of the references that I use for preparing this talk. I think that's the end of it. I'll leave you there and we are open for any questions. Thank you for listening.
Thanks so much,
Very
Shaun.
good.
That
Thanks,
was an
Shaun.
excellent and extremely concise presentation. Is there any questions from the audience? I don't see anything in the chat. Okay. So Shaun, just from my side of things, I think you did sort of mention this point, but just to maybe labor it a bit more, is that the risk of colorectal cancer in ulcerative colitis is really mainly driven by severe chronic inflammation and hence the need to treat to target mucosal healing and ideally histological healing. So just for you, if you want to just comment that the pseudopolyps themselves do not inherently increase the risk of malignancy. It's that they are a marker of severity and that they make dysplasia difficult to perform in detail. Do you want to comment on that?
Yeah, so as you mentioned, the risk is for colorectal cancer is dependent on the presence of inflammation. So as long as you can get the mucosal healing under control, in other words, turn the mucosa to as normal as you possibly can endoscopically, that reduces the colorectal risk. And when you see those pseudopolyps, all they're telling you is that this patient had a severe extensive colitis prior. It doesn't actually tell you that you currently at that endoscopy have a extensive colitis. The problem with all these patients that you see these pseudopolyps, it's not where you're seeing these isolated adenomas that we detect. There's multiple of these polyps, and often they matted. Sometimes they grow across the lumens, which makes visualization of the rest of the mucosa quite difficult. You can often see normal mucosa interspersed between them. So you might not be able to see dysplasia. Therefore, you have to take some time at endoscopy. And I think the point that most of the societies was advocating was that you need to actually have a surveillance plan in these patients because you can still miss dysplasia because of the symptomatedness of these lesions. But just removing them erroneously, it's not indicated because you're not going to reduce the overall cancer risk in them, as they're not really cancerous tissue. They're just a marker of healing, like basically excessive healing that has occurred.
Okay, great. And in terms of an impossible colonic stricture, so my understanding from your very concise overview is that they really should all have surgery. Would that put it in a nutshell?
In a nutshell, yes, because you don't know what's at the oral end of the stricture. You
Yes.
can assess the anal end of the stricture, but you haven't assessed the stricture properly if you haven't assessed the oral end of the stricture. You can do cross-sectional imaging and get additional information in that, but in a patient with ulcerative colitis that has a persistent stricture, especially as a long stricture, and has other risk factors, the risk of colorectal cancer is quite high in those cases, and surgery should be an option. Or you should discuss the patient for surgery.
Absolutely.
Yeah.
And in terms of the extent of surgery, I mean, I've always been sort of the opinion that once you make a decision to do surgery for ulcerative colitis, that it should really be a subtotal or total colectomy. Is there any place for a segmental resection here for a shortish stricture?
Yeah, so that was
An
actually
impossible stricture. Yeah.
the initial, if you go sort of back in time, 5-10 years ago, the feeling was that you should do a total subtotal colectomy for these patients. There was a small period in the middle there where segmental resection was advocated because you're dealing with somebody that's got disease in remission. But when you're operating on them, all you're doing is removing the risk for cancer in that particular segment, but you're still leaving colon behind. So that inherent risk of ulcerative colitis that's not in remission, you haven't actually dealt with that, and that patient then needs close surveillance. So in certain patient settings, you could opt for segmental resection, but ideally, if you're going to operate in patients with ulcerative colitis, you should just remove the entire colon in its entirety. But there is a subset of patients where a segmental resection is appropriate, especially if they've been in long remission for a decade or more. But that should be discussed at an MDT and with shared decision making with the patient, understanding the risks that they still need ongoing surveillance.
Absolutely. Are there any colorectal surgeons on the call that would like to comment on the topic of a total or subtotal colectomy versus a segmental resection? Anybody? Or any gastroenterologists that would like to comment on that?
Jill, can I ask a question, a different
Yes,
question?
Andy.
But yeah, I think the vogue for segmental colectomy and ulcerative colitis went long ago. So I think if you decide it comes out, it should come out. But my question is, I must admit, I haven't seen many strictures in ulcerative colitis during my career, and they are quite rare, I think. And the main thing that you think about is how you differentiate them from Crohn's strictures as much as you differentiate them as being malignant. So what? Because Crohn's are probably about 3 or 4 times commoner and can occur anytime during the disease. So is there anything in your algorithms that leads you to the differential diagnosis of these strictures other than malignancy? Shaun.
Sandy, you're addressing that question to Shaun, I assume.
Yeah, absolutely.
Yeah. So with Crohn in itself, you want to know if there's other evidence of narrowing or stricturing. Is the terminal ileum normal? Is there small bowel disease? Do you have associated perianal disease in these patients? Often what is reported is these patients often have small, short strictures, sometimes long strictures in just from extensive severe pancolitis, and it's often in the left side of the colon. So you should consider it, but in most of the time, if there's no small bowel disease and the terminal ileum is normal with no perianal disease, it's unlikely for it to be a stricture related to Crohn in itself. So it's then important to note at that index endoscopy what the assessment was when the patient had the extensive colitis originally. Because remember, you're dealing now with a patient that's developed a stricture post therapy. So that would have been obscured your sort of vision. I don't know if you want to add anything to that, Joe.
No, I think that's exactly right. And you've also got to just take the patient as a whole. Shaun, just one thing. So, I don't know the answer to this, to be perfectly honest, but in patients who've been in long-standing remission in ulcerative colitis on advanced therapies such as an anti-TNF, it's generally recommended by most societies that one can then discontinue fiber-aminosalicylates because the inflammation is mostly driven by, the cancer risk is mostly driven by inflammation as such. What's your feeling about that? I mean, in a patient who's got pseudopolyps, etc. I mean, I feel, just so this is me personally, that one should continue the 5-ASAs. I don't know what your feeling is on that.
Yeah, that's an interesting point because I came across it as well, especially in patients that are on advanced therapies where they say you should there's no need for the 5-ASAs, but whether or not the 5-ASA is chemoprotective in those patients is debatable because the quality of the evidence isn't that robust. Our practice is still, we leave them on a very low dose of lowest tolerable dose of a 5-ASA. So it's just that inherent risk that might be there. So yeah, I think you individualize the patient and you opt to what's best that you see over time. So I must admit, we still tend to leave them on that little bit of 5-ASA in our practice.
Yeah, we do that too as well. Often because we can't, get advanced therapies for everybody, and if we do, we're limited by doses and all the basic cost constraints. So yeah, I 100% agree with you. Any questions from anybody? VG, Chris? I can't see who else is actually on.
VG has his hand up.
Oh, VG,
Oh.
sorry, apologies.
Oh, okay. Oh, okay. Joel, yeah, just to speak to the stricture that one may occasionally find in a patient with ulcerative like colitis. So usually these patients are asymptomatic. They usually are there for their, after 8 years or so, for their screening, like in colonoscopy. So we've had, over the years, not too many of these. I can think about 4, maybe 5 of them. And the key thing is, can you go across it or you're not? Now, if you are unable to, then you can switch over to a slimmer scope, such as a pediatric colonoscope, but sometimes you can't find those, or if you're in a very resource strained area. The other option that we usually use is to just use the upper scope, and you'll actually be fairly surprised how many times in a patient with your long-standing ulcerative like colitis, you're able to actually reach the ileum using a upper scope, because usually it's a bit of a scarred like colon, and it's a bit shorter and easier to reach the cecum. So the key for me always in these patients with strictures, the 4 or 5 we've had, was, am I able to go across it? And if I'm unable to, then we speak to the, at the outpatient visit with regard to options. So we can do some CT scans and enemas and imaging, but then we usually speak about the option of an operation versus doing a endoscopic balloon for the patient, and then trying to see if we can still traverse the stricture, and obviously take numerous samples for history. And if there's any concern, if there's high grade, low grade dysplasia, high grade dysplasia, then we have a conversation again. And there it's really for a full colectomy. We also will not advocate for any limited resection or hemi-colectomies.
Thank you, VG, for that. Any other questions, comments? We have a bit of time. No? I don't have anything else to ask. Thank you, Shaun. You've covered everything extremely well. So I'm going to actually end the meeting then, if there are no other.
Sorry, Jill, I didn't raise my hand. One more thing for the fellows or the new ones who are learning is sometimes you really get these severe pseudopolyps. They're fairly easy to snare off, so and safe. So if you are learning, and you do find a patient with ulcerative colitis who has extensive pseudo like in polyps, and you want to just start to learn how to use a snare and to provide adequate histo, they're usually fairly easy to learn on. The other thing about pseudo like in polyps is they can, if you haven't seen them or you're not familiar with them and you see them for the first time, and as was mentioned, these patients are usually fairly asymptomatic, or their symptoms are mild. It often scares the sort of inexperienced, and you really think something needs to be performed urgently, upgrade their treatment or upscale them or refer them for surgery. So I think it is one of those situations where you must just remain calm and have plenty of images that you can share with maybe an experienced IB experienced physician or surgeon as well.
Yeah, thanks, VG, for that. Again, any last takers before I close up? Okay, so with that, Shaun, thank you so much. That was really an outstanding presentation, and my apologies for not being able to introduce you. Luckily, my internet issues did resolve themselves. So thanks very much again, and also thanks to iEcho University of New Mexico and the iEcho India team. The recordings are available on the Gastro Foundation website. Thanks, of course, to the Gastro Foundation, in particular, Chris, and of course, Cheryl, and thanks to all of our sponsors. So next week's session is pathology, so I hope you will all join. So thanks, everybody, for being here, and this is our last IBD session of 2025, so we'll see you again in 2026. Have a good evening.
Thank you.
Thanks, Jill. Thanks, Shaun. Excellent presentation. Thank you.
Thank you. Thanks. Bye.
Thanks. Bye.